Thank you, Dr. Mulshine and Dr. Woodkirk, for the invitation. I thought I may take it on, first of all, my conflicts, none to be revealed, through a few stages very quickly in view of the fact that there are some trainees among us and people that may not be familiar with the history of this particular investigation looking for cardiovascular disease and CT scans. I'll give a very brief summary about the feasibility, the accuracy, the prognostic value of these findings, and the new development with artificial intelligence. Just brief mentions all of these points. So one initial point that I would like to make, and that was just published, as you see here, the publication is just a month ago in Journal American College of Cardiology, is that the adjusted mortality rates for cardiovascular disease have dropped in the United States. This is an North American statement over the past 30 years. Although there's been a slowing of the dropping, or there's been a deceleration in the dropping over the past few years, maybe with a little bump up during COVID because of comorbidities. But as you notice in point 2 and 3, ischemic heart disease, IHD stands for ischemic heart disease, is still more than threefold more frequent as the mortality cause than all three cancers, main cancers combined. So yes, lung cancer is a problem, prostate cancer is a problem, breast cancer is a problem. Guess what? Ischemic heart disease remains 3 times more frequent and more problematic. So let's have a focus on coronary disease or cardiovascular disease while we're thinking of all these other important causes of mortality, but that take, in my view, a secondary, almost a setback, a seatback compared to cardiovascular. Now, some of the usual suspects I'll mention in all these publications. Dr. Yankovic very prominently in all of these publications here, and many others that I will show, Dr. Woodkirk and Stillman, all these names that will recur in many of these publications. We've been talking about coronary cardiovascular screening for a long time. We've been talking about screening for coronary disease by CT scanning, both in dedicated gated CT scanning of the heart and in non-CT scanning, non-gated CT scanning for lung cancer screening or non-lung cancer screening purposes for a long time. As you can see here, for several years now, we've been talking about how to score the severity of coronary disease on all of these scans. Shall we use just qualitative statements such as mild coronary calcification, severe coronary calcification? Should we do a more orderly type of screening or scoring rather? Like for example, these ordinal scoring talks about a score from 0 to 12, number of segments involved by coronary calcium in number of coronary arteries calcified. And do they work? They seem to be working. In fact, if you look at some of these publications and some of the others that I'll show, such as this one, for example, it seems to work. No matter how you look at coronary calcium, no matter how you quantify it, if you do see coronary calcification, even on a 6 millimeter CT scan performed of the chest, performed for completely different reasons other than screening for coronary artery calcification or for lung cancer, they all predict cardiovascular morbidity and mortality. This is an interesting sub-study of the Nelson trial. The Nelson was published, if I'm not mistaken, in 2011. This was published in 2012, a sub-cohort study looking at the event rate due to cardiovascular disease. Again, due to the presence or absence of coronary artery calcium. You can see for yourself, all-cause mortality, cardiovascular endpoint, coronary heart disease endpoints, they all increase with increasing calcium. That's not a surprise. We would expect that. But one secondary point that I would like to highlight from this particular study, and many that I will show later, is that although many of these patients do have an indication for preventive therapies, they're not actually getting them. If you look at the last line here, over or about 50%, the 43, the 57, the 48% numbers of patients with over 1,000 calcium score for coronary arteries do not get antihypertensive medications, do not get statin therapy, do not get whatever, an aspirin. So are we surprised that they continue to die? These patients have an indication for cardiovascular prevention, yet they're not on simple cardiovascular preventive medicines. Lung. This is another study by our own group in Italy. Significant drop in cardiovascular death at 11 years, yes, due predominantly to change in smoking habits, but look at that, use of cardiovascular drugs. Yes, the cardiovascular mortality dropped in lung cancer screening patients if you implemented primary, or maybe secondary in this case, preventive therapies. So the importance of implementing it. This study goes back to 2019. I will show you more recent studies in 2023-24, where the prevalence of use of statins in patients with screening for lung cancer is still minimal. So these are more, and this is a study published from Canada, just because I represent Canada at this meeting, from my colleagues in Ottawa, where they implemented actually a state-wise or province-wise Ontario Health Lung Cancer Screening for people at high risk. Again, here with mean follow-up of 50 months. And you can see here the quantification of coronary calcium, again, a very strong indicator of probability of cardiovascular outcome. In this particular study, although the age is only 50 on average, these patients have coronary calcium in over 90% of the cases. And they have a very high risk of dyslipidemia, diabetes, hypertension. So again, the importance of treatment. You can see here the calcium is an indicator of or a predictor of cardiovascular event, even after adjustment for non-cardiovascular death as a competing risk. So focus on coronary disease as you focus on lung disease. That's essentially the bottom line of this study. I'm going to skip through some of these because you've seen some of the slides already, because the concept, I think, is quite clear at this point. Yes, screening for all three is important. All three predict cardiovascular, outcomes. But the real question that the organizers or the meeting had for me is, does it change the natural history? Do we make a difference? Let's look at the two famous studies, the NLST and the Nelson, two trials, important trials, that looked at the reduced mortality due to lung cancer with lung cancer screening. Okay, so they reduced lung cancer screening mortality. What happened to the other mortality? The American study, 20% reduction in lung cancer death. But what about the other causes of death? Cardiovascular disease, 26%. That's the incidence of cardiovascular disease, 26% due to cardiovascular disease. COPD, about 10%. Other cancers, 22%. If you look at an all-cause death reduction in that study, grossly, it appears that all other deaths were also reduced. But if you exclude lung cancer death from that all-cause mortality, actually all other causes of death were not reduced, which means that we didn't do a good job at paying attention to other diseases. Am I wrong in interpreting the statistics? How about Nelson? Very much the same. So, yep, we reduced lung cancer. What else did we do? Nothing. Time to do something else. So, does incidental detection of coronary disease change the natural history of the disease? Well, incidental calcium discovery should prompt initiation of preventive therapy. I already said that. Approximately 80 to 90% of LCS patients are eligible for statin therapy, but calcium, and it is known that calcium improves adherence to prescribed therapies, at least from published evidence that I didn't report here. And since statins and other lipid-lowering therapy reduce the vulnerability of coronary plaques, it should be expected that we reduce cardiovascular events. Do we have the evidence? That's the question. So let's look at two studies that I can quote that may give a partial answer. One is an observational study, a Walter Reed Army study, and the other one is Vesalius that was just published about a couple of months ago. Walter Reed Army study. This was a screening study performed in Army personnel in the United States. As you see here, in over 13,600 military personnel, mean age 50, 71% were men, and followed for an average of 10 years for cardiovascular death, MI, or strokes. Simple interpretation of the data. You see the red lines on the left side? The left lines are outcome, so cardiovascular outcomes in patients with 0 calcium score, on or not, with or without statins. In other words, if you have no visible calcium, a statin makes no difference. The blue lines instead identify mortality in patients who had visible calcium and received or did not receive a statin. Hence, if you see something, do something about it. It makes a difference. That's an observational study. It wasn't an intentional study. The treatment was left up to the physician and a coordinated decision with the patient. Now, what about the Vesalius study? This is a very large trial designed to answer the question, if I take a very high-risk individual, defined as a patient with diabetes, smoking, coronary artery calcium, or CKD, and any other risk you want, but without previous cardiovascular disease, and randomize them to very intensive lipid-lowering therapy, do I reduce mortality? Remember, one of the markers of very high risk here was a high coronary artery calcium. By itself, it was considered a marker of high risk. So patients were randomized to I-ELCAP, which is one of these monoclonal antibodies to reduce LDL. And as you can imagine, the LDL was dropped by about 50% with the intervention. And the outcome was the cardiovascular death, MI, and strokes were reduced by about 25% with the intervention. So indirectly, although not all of these patients were screened for coronary artery calcium, but a large number of them were, indirectly we can assume that intervening on the presence of cardiovascular or the evidence of cardiovascular disease, it makes a difference. The new lipid guidelines in the United States were released 3 days ago, and they talk all over about coronary artery calcium. If you see calcium, do something about it. In no matter what type of imaging technology you identify it. You can use CT scans, you can use even chest x-rays if you see coronary artery calcium. Do something about it. The absence of calcium score of 0, in the presence of I-LDL, that's left for discussion between the patient and the doctor whether a statin should be initiated. But the presence of calcium, no matter how you identify it, is a strong indicator for intervention. Bottom line here, we go back to 2012 and compare it to 2019, 2022, 2024. How are we doing in screening and treating other problems? We're doing poorly. As you can see in this particular publications, still a large number of patients with a strong indication for prevention do not get it. It's time to do something about it. Yep, lung cancer screening, but what about the heart? 3 times more deadly. Artificial intelligence may help. I'm not going to stop there because there are dedicated sessions to artificial intelligence. But as you know, Morteza Nagavi and his group are very active, and many others are very active in this field. They may help with identification, scoring. According to some early publications, artificial intelligence may be superior to even native intelligence and your human eye to detect disease and report risk. This is a publication that I received from my friend Dr. Udkirk here, an interesting analysis of what are the challenges for implementing all of this. There are many challenges listed in this article. Inconsistent reporting across platforms, across different clinics and universities, low awareness of the importance of coronary calcium among the interpreting radiologists, the lack of standardization on reporting, hardware limitations on detecting what we want to detect, the definite increase in workload for the radiologists that would have to do more than just reporting on lungs and COPD and lung cancer. Maybe AI software implementation can help and should probably be implemented in doing an automatic reporting or at least automatic highlighting of the problems seen on CT scanning. And then finally, and this is my last slide, the cost and effectiveness of all of this. Is it cost and effective? Well, there was an interesting discussion earlier during the conversation that preceded this session. How do I assess cost effectiveness? Well, it all depends on how much money you're willing to spend. What is a good wine? How much you want to spend? What's a good dinner? How much you want to spend? So if we think that a year of quality life added to your life is worth $50,000, then a cost-effective screening may be $150. But if you want to spend $80,000 for a life of year added, maybe it's cost-effective to spend $600 on a scan. It depends on who you're scanning, low risk, moderate risk, high risk, and how much you're willing to spend society-wise. That's why, correctly so, the comparison of cost effectiveness between countries is going to be extremely different, or difficult rather, because there are very different concepts behind of what is cost effective. So thank you for your attention.